task, inshallah, will be done by Dr. Majed Almadi, who is a new energetic consultant and assistant professor of gastroenterology and endoscopy and endosonography at King Khalid University Hospital in Riyadh. And his lecture will be a continuation of the previous excellent lectures. And the title of the lecture is there still a role of EUS in pancreatic disorder? Well, I thought that this is the only, probably the best role for EUS is to help in pancreatic disorders. So I don't know how will be the debate in the lecture.
It's going to make my job much easier. Thank you very much. Bismillah ar-Rahman ar-Rahim. So hopefully I'm going to be able to convince you that there is a role for EUS in the pancreatic disorders. And we'll walk you through it bit by bit, and we'll just cover a few of the topics because the topic is a bit lengthy. So we'll take, firstly, acute biliary pancreatitis. The initial motion was that anybody with pancreatitis would get an ERCP, and that would result in some therapeutic effects, but at the same time you're risking the patients of each procedure will risk of pancreatitis and bleeding and perforation. EUS can easily detect CBD stones very easily, and you can see the stone lying in the mid-CBD here, and with a nice shadow after it. So EUS has evolved to take over ERCPs. And if you look at the recent systematic review, looking at multiple studies, if you use an EUS-based approach for biliary pancreatitis patients, you can be able to avoid about up to 75% of ERCP procedures. That means 3 out of 4 ERCPs are unnecessary. You do an EUS, there's no stone, you save the patient the procedure, he goes for a cholecystectomy. And that would decrease the morbidity and mortality associated with the ERCPs dramatically. So for acute biliary pancreatitis, I think it's a go. EUS does play a role. Let's see about pancreatic cancer. Now, the efficacy of the EUS in detecting pancreatic cancer is very well documented. But looking at a meta-analysis comparing PET to a combination of PET and CT scan versus EUS, the sensitivity is much better for a PET combined with a CT scan. It reaches about 90%. But if you go to specificity, EUS beats both modalities with 93% specificity and a diagnostic odds ratio of about around 50. So it's higher as a specificity and a diagnostic odds ratio, but sensitivity-wise, a combination of PET-CT is better. Now, where does EUS fall in the evaluation of pancreatic cancer? Different guidelines give it different weights. We know that you don't need to biopsy any lesion that's resectable and you think it's pancreatic cancer. You don't need a tissue diagnosis, you go to surgery directly, just because the negative predictive value of EUS is pretty low. That means if you don't get it on EUS biopsy, it doesn't mean that it's not cancer. So it shouldn't delay surgery by any means. And if you do need to get a tissue diagnosis, EUS is the way to go. It's safer, and the efficacy will go through the biopsy results. But FNA is very sensitive and specific for pancreatic lesions. The Japanese guidelines give it more heavy weight, and it gives it a strong recommendation when necessary to perform an EUS. And they give it the same weight in staging for tumors. Now, if you go to the National Comprehensive Cancer Network, in the evaluation, the initial evaluation, you go to pancreatic CT for the initial evaluation. If there is a mass and no metastatic disease, you can consider EUS. If there's a mass and metastatic disease, you can get the tissue diagnosis, and usually that can be accomplished by EUS. So you can find the EUS in both arms of this algorithm. If you don't find a mass on your imaging technique and you don't have metastasis and you still think the patient has pancreatic cancer, EUS is the way to go. EUS beats imaging modalities for pancreatic tumors less than 2 centimeters in size. EUS has a very high sensitivity for it. Or you can go for an MRI, MRCP. And metastatic disease, the same as the first arm. So you can find the role for EUS however way you put it. One place that EUS beats other imaging modalities for neuroendocrine tumors. It's much more sensitive, and you can see that by comparing in a study compared neuroendocrine tumors all in all. The sensitivity of EUS was about 91% compared to 63% for CT scan. But that's really mainly driven by insulinomas. Insulinomas are much more easily detected by EUS, and by CT scan you see here the detection rate is about 31% compared to 84% by EUS. So pancreatic cancer definitely plays a role. Asymptomatic pancreatic cysts, it's not so great. So if you talk about EUS-based FNA diagnosis of mucinous cysts, the ones we really care about that have the potential to change the cancer, the sensitivity is about 63%. It's not perfect at all. But if you look at the specificity, it's pretty good. 88% is not bad at all. And if you look at only prospective studies that reported, the pooled sensitivity is even worse. It's only about half the times you pick it up on FNA, and the specificity goes higher to about 92%. But what other modalities do you have for the management of mucinous cysts? You don't have much. You can't offer surgery to everybody. It's not recommended. And a strategy, a cost-effective analysis looking at the best strategy is it's EUS-guided FNA stratifying the patient risk of malignant potential. So asymptomatic pancreatic cysts, again, EUS does have a role. In chronic pancreatitis, you have a clinical setting, you suspect chronic pancreatitis for one reason or another. Your EUS can pick up the lobulations, it can pick up the strands, and you look at the pancreatic duct, it looks irregular with a hyperechoic wall. All of these features are part of the evaluation of chronic pancreatitis by EUS, and the diagnostic criteria are available and known. It relates to pancreatic parenchyma and ductal changes. So compared to other modalities to diagnose chronic pancreatitis, EUS versus secretin-stimulated ERCP, they're both equal in sensitivity and specificity, but EUS beats it. It's much more safer than an ERCP, and secretin-stimulated ERCP is not something that everybody does, and it's very cumbersome to do. So it's better than ERCP, that's for sure. And if you compare it to MRCP, the sensitivity is much higher for EUS if you use it alone, as compared to MRCP only. And if you use both criteria, either or, your sensitivity goes up. And the specificity, again, goes pretty well for EUS on its own. So chronic pancreatitis, again. How about contrast-enhanced EUS? This is, you do an EUS, you find a lesion in the pancreas, you think it's homogeneous, irregular margins, and you think it's a neoplastic process. You give the patient intravenous contrast, and the lesion does not light up, but the perivascular area lights up. That's characteristic of pancreatic adenocarcinoma. It does help, in a way, looking at the evaluating a patient with pancreatic lesions, whether they be malignant or benign. So the sensitivity of contrast-enhanced EUS is pretty high, 94%, and the specificity is about around 90% again. So it's pretty good. That's another. Where it falls exactly in the evaluation, does it add more than FNA? We're not sure. Elastography used pressure on the probe itself. You press on the lesion. This is a lymph node that's round, and it's suspected to be a neoplastic process. So what you do is, by pressure, red is soft and blue is firm. And the firmer the lesion, the most probably it's a neoplastic process. And you can see here, this is mostly blue, so it looks like a firm lymph node. Most probably it's neoplastic. If you go look again at this lymph node under it, it's triangular. It looks benign. And if you use the elastography again, it mostly falls in the soft part, so it's not a firm lesion. It most probably is a benign lymph node. So for solid pancreatic masses, elastography is pretty sensitive in picking up pancreatic tumors, but it's not specific. So it's not great for pancreatic lesions per se. It might have value more in lymph nodes. It's very sensitive for lymph nodes, 88%, and very specific. So if you have a lesion, you think it's neoplastic, and you have multiple lymph nodes around it, you might use it to target which lymph node to biopsy, just to confirm that this is a metastatic lesion rather than a benign reactive lymph node. So elastography does have a plate role. Now how about FNA? If you use a strict diagnostic malignant cytology as a pancreatic cancer adenocarcinoma, the sensitivity is about 85%, and the specificity is about 98%. So it's you don't get any better than this. If you loosen your criteria and include atypical cells as positive and suspicious cells, and on top of malignant cells, your sensitivity goes up to 91%, and you lose a bit of specificity, which is natural, and you'll have to choose your cutoff. Where do you want to draw the line between positive and negative? It's pretty safe. The specific morbidity associated with FNA is about 1%, and a meta-analysis of more than around 11,000 people, and it's mainly more than two-thirds of it is pain and pancreatitis that's mild and self-resolving. Okay, so celiac plexus block, that's another option. You go through the GE junction, you locate the celiac axis trunk, you puncture a needle and you inject drugs in the celiac plexus around the celiac artery. This is used for pancreatic cancer and chronic pancreatitis for pain control. A systematic review looking at it, it showed that it improves pain scores pretty well, but you lose effect with time. So at 4 to 8 weeks, 55% of people are free of pain. At 12 weeks, it drops to half. And again, at 24 weeks, it drops later. So it loses effect with time. But the other side of the equation, it's pretty safe with no major complications. A recent Cochrane systematic review looked at the use of neurolysis, that means alcohol to ablate the nerve directly for pancreatic cancer. And what they found is it's better than analgesic therapy in controlling pain, and it's almost at 8 weeks loses its effect, although there's a trend, but it crosses zero. What's more interesting is the opioid use. It's much less at 4 weeks than people who didn't have neurolysis, and this effect is sustained up to the death of the patients. So you have less of the effects of narcotics with cognitive impairment, constipation, and other complications of using narcotics for pancreatic cancer. So that's one way to do it. You've made my job easier, Doctor Iyad, going through the cysts. But pancreatic drainage procedures for pancreatic fluid collections and peripancreatic fluid collections is one of the most useful ways of using a EUS. This is an 18-year-old male. He presented 1 year after a RTA, a road traffic accident, and he had a big cyst in his abdomen. He came with abdominal discomfort, nausea, loss of appetite. He can't eat really much. And you can see this lesion is about 10 by 8, and it's compressing the gastric outlet. This is on coronal imaging. You can see it's a bilobed thing, and it's in its diameter, it's about 13 centimeters. So we took this guy for a EUS guided cyst gastrostomy, and we went through the stomach. What you do is you go with your EUS probe, locate the cyst, have a look at it, avoid vessels, puncture it with a needle, then you put some wire in just to facilitate the insertion of stents, and you dilate the tract with a balloon up to usually 18 to 20 millimeters. And then you drop in some double pigtail stents, and this is it after the end of the procedure. You have 2 stents in place. This was the first case we did. We didn't have short double pigtail stents. These are too long. The last few cases we did were with shorter stents. After 3 months, we removed the stent endoscopically, and this is the CT scan with a very minimal remnant. It's about 1.5 by 1 centimeter remnant at the body tail of the pancreas, and the patient remains asymptomatic. We've done about 5 cases over the last year, and they've all been successful, alhamdulillah. So the advantages of EUS guided endoscopic drainage: it's less invasive than surgery. It preserves the organ. There's no pancreatectomy with surgery, and you're able to characterize the cyst as opposed to endoscopic drainage without EUS. You might be draining a neoplastic cyst rather than a pseudocyst or a walled-off necrosis. And you don't need a bulge. Usually if you're going to do it endoscopically, you need to see a bulge in the stomach itself before you proceed for a drainage procedure. And it avoids blood vessels, thus decreasing the risk of bleeding. It has to be close to the pancreas, that's a limitation, and it has to be encapsulated, meaning a mature cyst. And it may be a temporary measure, and it doesn't assess the underlying problem. If you have a fistula or you have a leak, it might not resolve, and you might need surgical intervention. It's very successful, up to 100% of the time, and clinical success is up to 100%, and the least is about 75%. So it's very, with limited number of complications, and looking at the other options, it might be the best way to go. So the last thing is we're going to talk about EUS facilitated CBD cannulation. This is in cases when you have pancreatic masses in the pancreatic head or acute pancreatitis, and you can't cannulate the common bile duct. There are more than one way to approach it, either going through the transhepatic route, going through a dilated duct from the stomach into the liver, and then facilitating cannulation, drawing a wire, or you go through the duodenum and go into the common bile duct at the level of the second stage of the duodenum, get a wire out, and then you do your rendezvous procedure. So this is how it's done. If you're going to do it from the duodenal wall, you locate the CBD under endoscopic guidance, you puncture it with a needle, and then you put your wire through, and then you exchange and come back out, and continue with an ERCP. This is a lady we did about a month ago. She had CBD stone, came with pain, had pancreatitis after the first ERCP that failed. A second ERCP 2 days later because she was developing cholangitis. We tried to get in, did a needle knife, couldn't get in. After talking to the surgeon and the family, they agreed for us to try to do this. Abid was around, Dr. Abd al-Haybi, otherwise I wouldn't have even tried. He was around, so we tried to do it both together, and it worked pretty well. So this is the EUS scope, and you can see a needle coming out. After you locate it with your